Okay, guys. Good morning, everyone. Today we are going to continue our book club regarding the book Fundamentals of Diagnostic Radiology, the fourth edition, with your colleagues, Dr. Kamel Abdelmajid. He will present the chapter about the CNS infections.
Thanks, Sir Dr. Ahmed. Good morning. Our topic is central nervous system infection. Central nervous system infections compose of four portion: congenital infection, extraaxial infection, parenchymal infection, and AIDS-related infection. First, congenital infection. Prior to widespread availability of CT, pyogenic abscess of brain carried 30 to 70 mortality rate. The mortality rate has dropped to less than 5% because of accurate diagnosis and localization of the lesion. MRI is usually modality of choice for central nervous system infection than CT. However, CT can be used for unstable or uncooperative patients. Congenital infection of fecal and neonatal brain, commonly referred to torch infection, include toxoplasmosis, other infections like syphilis and varicella, rubella, cytomegalovirus, herpes simplex. These infections often result in significant brain injury and congenital brain malformation. First, cytomegalovirus infection, the most common cause of congenital central nervous system infection. Maternal infection results in transplacental transmission to fetus. Postnatal infection via viral shedding in breast milk result in periventricular pattern of injury and dystrophic calcification, usually no calcification of basal ganglia. Periventricular white matter loss result in ventriculomegaly and microcephaly. CNS malformation are less in patients infected later during gestation. This picture, congenital central nervous system infection, non-contrast CT scan show periventricular dystrophic calcification. Toxoplasmosis follow cytomegalovirus infection in frequency caused by Toxoplasma gondii. Infection occurs after pregnant it is undercooked meat or exposed to cat feces, resulting in microcephalic chorioretinitis. Imaging study reveals atrophy, dilated ventricles, dystrophic calcification, calcification seen in white matter and basal ganglia and cortex. Yes. Toxoplasmosis, exact. Herpes simplex, infection result during delivery when the patient has herpes virus type 2. Central nervous system infection causes diffuse encephalitis with infarction, present with fever, rash, and lethargy and seizure, microcephaly, microphthalmia, enlarged ventricle, intracranial calcification, multicystic encephalomalacia may occur. Early in disease, cranial ultrasound show areas of increased parenchymal echogenicity. CT shows area of hypodensity and MRI T2 hyperintensity. This is a case of neonatal herpes simplex encephalitis. Non-contrasting image of 2-week-old child shows hypodense swelling in the right temporal lobe and to a lesser extent in the left frontal and left temporal lobes. 3 weeks later, non-contrast CT revealed multiple areas of cystic encephalomalacia, widespread gray matter calcification also seen. Congenital HIV infection can occur transplacentally or postnatally via breast feeding. The opportunistic infection and neoplasms seen in adults usually not observed in young children. Primarily affect white matter and basal ganglia. Symmetric calcifications seen in basal ganglia, but especially the globi pallidi are best seen with CT scan. Other infection, rubella, now very uncommon because of widespread immunization. Transplacental transmission takes place during maternal infection. CT scan reveals dystrophic calcification in deep gray nuclei and cortex. A calcification seen in basal ganglia. Other portion of part of central nervous system infection, extraaxial infection, include extraaxial pyogenic infection can involve both the epidural or subdural spaces. Both epidural and subdural abscesses or empyema may result from paranasal sinusitis, orbital infection, penetrating injury. CT and MRI show an extraaxial collection with increased density or increased T1 and T2 signal intensity compared to CSF. The margin of collection usually enhanced smoothly with contrast. MRI is more sensitive than CT for both epidural and subdural empyema. Cranial ultrasound demonstrates heterogeneous echogenic extraaxial collection. Epidural and subdural empyema. Epidural empyema are generally confined by dural attachment. This prevents rapid expansion, account for their lentiform shape and convex inner margin, while subdural empyema can spread more easily through the dural space and become life-threatening.
That's why we should be more careful in subdural antibiotics because they are life-threatening.
Yes.
So epidural are less likely, but that doesn't mean we don't need to be careful with that, but it's much more easier to report epidural than subdural.
This contrast enhanced CT epidural abscess. Image of 30 years old child present with frontal sinusitis and headache. There are two adjacent anterior frontal lentiform shaped epidural collection of intermediate density paths. One of the collection extend and cross the midline anterior to the falx. Both collection enhance smoothly.
The contrast enhancement is typical first, second, while hemorrhage has some sort of trauma, for example. Actually, the density of the material is more than CSF in abscess, while hemorrhage might have some fluid to the potential and radiological
Subdural empyema, transaxial T2 weighted of this 8 years old child show a thin layer of hyperintense subdural fluid collection along the left cerebral hemisphere with mass effect. After contrast enhanced in T1 show hypointense left subdural fluid with dural attachment enhancement. Sorry. The same patient diffused weighted imaging show increased signal intensity of fluid, indicating empyema and not a sterile subdural effusion, which would be hypointense on this sequence, diffusion weighted. Subdural empyema can be hyperintense on diffusion weighted imaging, thus allowing them to be distinguished from subdural effusion, which can also enhance mildly. Subdural hygromas are identical to CSF. Mild smooth dural or meningeal enhancement may be seen after craniotomies and patient with ventriculostomy, benign and reflect chemical pneumonitis. Meningitis, sorry. Yes. All of CSF.
both of the approaches some mild enhancement, especially in patients with ventricular patients with overshunting, resulting in decreased intracranial pressure. This will result in smooth, diffuse meningeal enhancement.
This T1 like this case, this T1 contrast show benign post-operative meningeal enhancement several years after brain surgery. Contrast enhanced T1 reveals smooth but definitely abnormal enhancement of dura.
First, enhancement of the meninges.
Yes.
Second, there is revision. Third, you can see the ventricles completely collapsed,
Collapse.
which is not normal, even with revision. This indicates hypobacterial hypertension due to overshifting by the revision. However, this is a different feature. It's not an indication of some
Meningitis can be caused by bacteria, mycobacteria, fungi, parasite, or viruses. Bacterial meningitis is caused by Haemophilus influenza in children, while Neisseria meningitis in teenager and young adult, Streptococcus pneumonia in older. Meningitis caused by group B Streptococcus and Escherichia coli occurs in neonates. The inflammatory exudate caused by the meningitis may produce high density on CT and hyperintensity on FLAIR MRI sequences within the subarachnoid space and ventricles. Bacterial meningitis initial contrast enhanced CT scan of this 3-month-old boy is normal. Contrast enhanced CT scan obtained 1 day later show marked brain swelling. Focal areas of low density represent edema and ischemia in the frontal and occipital lobes. One month later, an intracranial ultrasound shows ventriculomegaly from marked cortical atrophy resulting from widespread cortical destruction. Subdural effusion contrast enhanced CT shows schizer with Haemophilus influenza. Meningitis reveal a subdural collection nearly isodense with CSF. Subdural effusion are common with Haemophilus meningitis. There is also enlargement of lateral and third ventricle due to communicating hydrocephalus, which is a common complication of meningitis. Tuberculous meningitis is the most common form of central nervous system tuberculosis. It is usually caused by Mycobacterium tuberculosis. Tuberculous meningitis occur in all age groups, but particularly in children and elderly. Approximately 5 to 10% of patients with TB develop central nervous system disease. Imaging study will show enhancing thickened meninges, especially along the basal system. In contrast, meningeal enhancement in bacterial meningitis is usually more peripherally distributed and less thick. Tuberculous meningitis contrast enhanced CT image shows markedly abnormal contrast enhancement of the left sylvian fissure, ambient cistern, and interhemispheric along the tentorium also. Irregular enhancement in the basal cistern is typical. Fungal meningitis usually causes thick meningeal enhancement in the basal cistern in a manner similar to tuberculous meningitis. Hydrocephalus is common, but infarction and extension of fungal infection into the brain substance occur less often than with tuberculosis or pyogenic meningitis, except in case of aspergillosis or mucormycosis. This is coccidomycosis meningitis, basal cistern enhancement, thick. Meningobasal or racemose cysticercosis occur when the larvae of pork tapeworm Tinea solium infest the subarachnoid space, especially the basal cistern. The larval cyst may grow in a grape-like cluster. These cystic lesions are isodense on CT and iso-intense on MRI. Intraventricular cysticercosis can be difficult to detect by CT and MRI since the cysts are usually isodense and iso-intense to CSF.
So what you see is cysts within the ventral lumen space.
Yes.
They're just like a dilated, huge ventral lumen spaces. It's not dilated, there are cysts around the vessels in the periventricular space enlarging. Okay? So this you should keep in mind. This is very, very typical for meningococcal
Also, the same cases, subarachnoid cysticercosis contrast enhanced sagittal T1 scan shows multiple non-enhanced cysts in the callosal sulcus and cingulate gyrate. The corpus callosum is markedly distorted. Intraventricular cysticercosis transaxial proton density weighted image, cystic mass in the anterior body of the right lateral ventricle. The lesion is slightly hyperintense compared to the CSF in the ventricle. The scoliosis is of high signal intensity in the posterior aspect of the cyst. Viral meningitis is caused most commonly by the enterovirus, but can also be caused by mumps virus, Epstein-Barr virus, Toga virus. Patient usually present with flu-like illnesses, fever, headache, and nuchal rigidity. Most patients don't require treatment unless infection progresses to encephalitis. Neuroimaging studies are typically normal, but mild meningeal enhancement can occur. Sarcoidosis is a non-infectious granulomatous disease of unclear etiology involving the central nervous system. Neurosarcoidosis primarily affects the leptomeninges, and abnormal leptomeningeal dural enhancement can be seen with both CT and MRI. Thickening and enhancement of cranial nerves and the hypothalamic pituitary axis are not uncommon.
with the infection, since it's not infectious, because the primary differential diagnosis in case of TB meningitis, they always look the same. Okay? And by the way, TB, usually you have a normal chest X-ray. So if you have normal chest X-ray, doesn't mean that there is no meningeal TB. You can, most of the time, you have meningeal TB with normal chest X-ray.
There is thickening of hypothalamic pituitary axis, also trigeminal nerve. Other part, parenchymal infection, pyogenic cerebritis, and abscess. Bacterial infection of brain may develop by direct extension following trauma, surgery, paranasal sinusitis, and otomastoiditis. Hematogenously spread infection occur even more frequently, especially in patients with lung infection, endocarditis, or congenital heart disease. Anaerobic bacteria are the most common organism overall. Infection with Staphylococcus aureus is common after surgery or trauma. With infection resulting from hematogenous spread, the frontal or parietal lobe are the commonly involved. The imaging appearance of cerebritis and brain abscesses correspond with four pathological described stages: early cerebritis and late cerebritis. Early cerebritis, within the first few days of infection, the infected portion of the brain is swollen and edematous, has ill-defined margins. CT scan may be normal or show an area of low density. MRI, the lesion is hypointense or isointense on T1 and hyperintense on T2 and flare. Patchy areas of enhancement within the lesion. A ring of enhancement is not present at early cerebritis. These images features are non-specific and can be seen with neoplasm or infection. While late cerebritis occurs within 1 to 2 weeks of infection, central necrosis progresses. Centrally, there is increased hypodensity on CT, hypointensity on T1 weighted, and hyperintensity on T2 and flare sequences on MRI. Diffusion weighted may show increased signal intensity at the center of the lesion. Some late central enhancement, no discrete T2 hypointense capsule is evident on MRI in late cerebritis. While early capsule, within 2 weeks, the infection is swallowed off as a capsule of collagen formed. Contrast enhanced CT and MRI show a well-defined, usually smooth and thin rim of enhancement. The rim tend to be T2 hypointense. Central necrosis again result in hypodensity on CT and T1 hypointensity and T2 hyperintensity on MRI. Prominent surrounding vasogenic edema usually persists. There is reduced diffusion with hyperintensity centrally on diffusion weighted. At the late capsule, in the late capsule stage, the rim of enhancement become even thicker and better defined and thicker. Multiloculation is common. Prominent increases signal intensity present centrally on diffusion weighted. The inner aspect of the enhancing capsule is often thinner than the peripheral aspect. This thin medial rim predisposed to intraventricular rupture of the abscess. Differential diagnosis of bacterial cerebral abscess includes the neoplasm, resolving hematoma, subacute infarction, or demyelination. The clinical features, combined with the appearance of prominent central hyperdensity on diffusion weighted, smooth complete enhancement rim, significant surrounding vasogenic edema, and T2 hypointensity of the capsule should strongly suggest the brain abscess. While neoplasm typically show irregular enhancement but rarely increase signal intensity on diffusion weighted. Resolving hematoma demonstrate obvious presence of blood product, and subacute infarction typically present with an appropriate clinical history and gyriform enhancement along the vascular territory. In demyelinated lesion, often the an incomplete ring of enhancement and accompanying characteristic white matter lesions. Early cerebritis, contrast enhanced tissue CT shows an areas of decreased density in the left frontal lobe, while transaxial T2 obtained at the next day show high signal intensity in the left frontal lobe and left frontal sinuses.
Four stages. Cerebritis. Itis means inflammation.
Yes.
Or not inflammation. So inflammation, late inflammation, early capsule, late capsule. Early inflammation is just edema, mild edema. Late inflammation is more severe edema. Okay? Early capsule is not formation of a capsule, but it's not very well defined. While late capsule there is a thick, smooth capsule. However, usually the inner border of the capsule is thinner. That's why it's ruptures into the vertebral system. Okay? The previous case was to late cerebritis. Now we have a capsule, we have a collection, we have an abscess here. Okay? You can notice the inner wall is thin on the contrast enhanced images, consistent with cerebral abscess. Complete enhancement.
2 weeks later, contrast enhanced shows a ring enhancement abscess with an early capsule. Late cerebritis, as in the CT, contrast enhanced CT scan demonstrate irregular enhanced peripherally and low density centers, vasogenic edema. This is a typical of late cerebritis stage of pyogenic infection. Multiple pyogenic abscess transaxial T2 weighted reveal a right parietal lesion with hyperintensity centrally and hypointensity peripherally. With hyperintense vasogenic edema. Two smaller hyperintense lesions are present on the left while contrast enhanced CT scan, contrast enhanced T1 weighted MRI show a thin smooth enhancement of all three lesions. The capsule. Pyogenic abscess. Contrast enhanced T1 reveals abscess that has extended into the atrium of the left lateral ventricle. The enhancement bacteria and intraventricular extension favor diagnosis of an abscess over the tumor. Pyogenic cerebral abscess. This case illustrates most of the classical features of cerebral abscess. Sagittal T1 show high signal rim of abscess. As a result of paramagnetic T1 shortening, transaxial T2 weighted show hypointensity rim from T2 shortening with hyperintensity centrally and significant surrounding edema. While on diffusion weighted shows hyperintensity centrally, characteristic feature of abscess is usually not seen in necrotic tumor, while contrast enhanced T1 show enhancement of the rim that is seen medially, predisposed to rupture. Mycobacterial infection. The most common form of central nervous system mycobacterial infection is tuberculous meningitis. Focal mycobacterial infection of the brain occur in two forms, tuberculomas and abscess. Tuberculoma is a granuloma with central caseous necrosis. In contrast, tuberculous abscess has characteristics similar to those of pyogenic abscess, but usually develop in patients with impaired T cell immunity. Tuberculoma. Most tuberculomas are not associated with TB meningitis. Infections spread to brain hematogeneously from the lung. Most tuberculomas in adults are supratentorial, involving frontal and parietal. 60% of tuberculoma in children are in posterior fossa, usually in the cerebellum. CT scan shows one or more isodense or slightly hyperdense nodule. A target appearing with a central calcification surrounded by a rim, enhanced rim. It is uncommon but strongly suggests a diagnosis. MRI tuberculoma may be high or low in signal intensity on T2. The wall of tuberculoma is often in hypointense on T1 weighted. T2. Tuberculous abscess is a rare complication since primarily in immunocompromised patients impaired T cell function. Grows more rapidly than seen with tuberculomas. The imaging features are similar to that seen with bacterial abscess. The lesions are often large and multiloculated. In distinction to tuberculomas, prominent edema and mass effect also distinguish tuberculous abscess from tuberculoma. Multiple tuberculomas flares show multiple small areas of T2 hyperintensity. Bilaterally, contrast enhanced transaxial T1 shows multiple small enhancing nodules. Fungal infection of central nervous system can be grouped into endemic and opportunistic categories. Endemic fungal infections are usually geographically restricted. They can occur in both immunocompetent and immunocompromised, immunosuppressed patients. Present predominantly with granulomatous meningitis, parenchymal disease is unusual, while opportunistic fungal infection occur worldwide, but usually in immunocompromised patients such as infant, elderly, and chronically ill patients. Parenchymal involvement is seen with much higher frequency with opportunistic fungal infection.
Since it's opportunistic,
Yeah.
you need to have immune compromise.
Endemic fungal infection. Most common endemic fungal infection in United States are coccidioidomycosis, North American blastomycosis, and histoplasmosis. These usually manifest as granulomatous meningitis. Coccidioidomycosis transmitted by soil fungus, Coccidioides immitis, spore inhaled. Less than 1% develop disseminated meningitis, while blastomycosis caused by blastomyces dermatitis, central nervous system infection occur in 6 to 3%. Meningitis is most frequent. While histoplasmosis, usually patient asymptomatic histoplasma caused by Histoplasma capsulatum, disseminated infection is unusual. Small percent of disseminated cases involve central nervous system, where in this meningitis is common. Endemic fungal infection, as seen with CT or MRI, most fungal granulomas are small and show solid or thick rim enhancement similar to tuberculomas. Fungal abscesses have an appearance similar to that of bacterial abscesses. Accompanying meningitis with meningeal enhancement is a common feature. Hydrocephalus is also common. The differential diagnosis include TB, multiple bacterial abscesses, septic emboli, and parasitic infection. This histoplasmosis granuloma contrast enhanced CT image show a solidly enhanced lesion near the right lateral ventricle. Most fungal granulomas are small and show either solid or thick rim enhancement. Yes. Yes. Opportunistic fungal infections. The most common opportunistic fungal central nervous system infection are Streptococcus, aspergillosis, mucormycosis, and candidiasis. These usually present as a meningitis, but focal parenchymal lesions are not uncommon in immunologically vulnerable patients. First, aspergillosis in involves the central nervous system in 60 to 70 of patients with disseminated disease, hematogenous spread, or by direct aggressive extension from the infected paranasal sinus, leading to meningitis or meningoencephalitis. Parenchymal disease usually takes the form of an abscess, which are often multiple and show irregular ring enhancement. The abscesses are frequently T2 hypointense centrally on MRI due to hemorrhage or presence of heavy metal. Disseminated aspergillosis contrast enhances CT transaxial portion density, proton density weighted sequence, show a large necrotic mass in the right frontal lobe and several smaller lesions in the left hemisphere. Contrast enhanced T2 previous case, surgically drained aspergillosis was found. The patient poorly controlled diabetes, the serum of enhancement and necrotic center. Disseminated aspergillosis transaxial T2 weighted show T2 hypo lesion in the right posterior body of the corpus callosum and at the gray-white matter junction of the left frontal lobe. The appearance of the larger right-sided lesion is due to T2 shortening paramagnetic effect. Contrast enhanced T1 demonstrate intense contrast enhancement of the larger active right side lesion. It's not active. Mucormycosis. Mucor invades the brain usually by direct extension from the sinuses, but hematogenous spread also occurs. Almost all patients are diabetes or otherwise immunocompromised. CT and MRI studies in patients with central nervous system mucormycosis will reveal single or multiple mass lesions with a degree of peripheral enhancement and vasogenic edema. Lesions are often in the base of the brain adjacent to the diseased sinuses. Lesion with peripheral enhancement, cortical sparing, and non-vascular distribution is more likely to be mucormycotic abscess than infarction. Flare sequence demonstrate T2 hyperintense edema and swelling of the rectus gyri along the inferior of the left frontal lobe, reflecting cerebritis. T1 show dehiscence of the roof of the sphenoid and smooth sinuses with extension of the fungal intracranial extension. Yes. Streptococcus, the most frequently reported central nervous system fungal infection. Cryptococcus neoformans is responsible for most cases in immunocompromised patients, while Cryptococcus gatti is reported mostly in patients with normal immune function. The usual manifestation is meningitis, but granulomas, cryptococcomas can occur in 10%. CT scan in patients with cryptococcus are frequently normal, with improved sensitivity of MRI. Parenchymal lesion and meningeal disease are seen more frequently than with CT. Cryptococcal gelatinous pseudoses are seen in immunocompromised patients. Parasitic infection, the most common infection likely to be encountered in the United States are cysticercosis and echinococcus granulosus and toxoplasmosis. Cysticercosis is caused by the larvae of pork tapeworm Taenia solium. Parenchymal cysticercosis is more common than meningobasal, have 4 stages. In the vesicular stage, viable parasites appear as a small, usually less than 1 cm or less, solitary or multiple round lesions that are hypodense on CT and iso-intense to CSF on MRI, peripherally distributed, no enhancement, no edema. While colloid stage show when the cyst die and its fluid leaks into the surrounding brain, imaging study now reveal ring-enhancing lesion with surrounding vasogenic edema. The date set further degeneration in the nodular granular stage, while the last nodular calcified stage is a dense residual calcification.
So when edema happens around the cystic that indicates that the fluid is leaking, that the cyst is big. However, when the cyst dies, there the problem starts. The patients get to deteriorate because the fluid adds to the dead cyst. As you can see here, there's scolex inside and
Scolex inside and
the edema surrounding it.
yes.
No, there's no edema. Marked edema.
The cysticercosis also contrast enhanced T2 show contrast enhanced this 3 sequence all show cystic lesion in the left frontal, the rim of cyst enhanced with contrast, and there is surrounding edema indicating that the cyst has died and fluid has leaked out and the scolex is visible. This is the edema around the lesion. Viral infection, herpes simplex encephalitis. Can I read? Herpes simplex encephalitis occur in immunocompetent patients of all ages. Neonatal herpes encephalitis caused by transmission of genital herpes simplex virus type 2 from mother during delivery. Herpes simplex type 1 responsible for majority of the encephalitis in other age groups. Herpes infection cause encephalitis or cranial neuritis. Herpes simplex type 1 contrast CT show hypodensity and edema of both temporal lobes. CSF studies are often initially non-specific. CT scan may be normal or show poorly defined hypodense region in one or of the temporal lobe. MRI shows symmetric or asymmetric gyral pattern of high signal in T2 and flare with predilection of the hippocampus and insular cortex. Reduced diffusion weighted and often present. Herpes simplex virus type 1 encephalitis contrast enhanced CT of 8 years of boy show low density at the right temporal lobe. Axial flare show prominent areas of hyperintensity in both temporal lobes with sparing of putamen. Very right. But yes. Acute dysentery. White matter. Yes. Yes. Yeah. Toxoplasm. After treatment, complete result. Yes. Finished. Finished.
To see and to know about it.